Let's go to Medicaid. You're very critical of Medicaid. You've written quite a bit attacking Medicaid as promoting worse health outcomes than other forms of insurance. And I think you and I would agree that the low provider reimbursement in Medicaid is a really serious problem. Uh,
Yeah, and this is one of the things that I really try to, one of my highest priorities in how I design this plan was to attack that problem, the problem of poor health outcomes and poor quality of health coverage for low-income Americans. And so, you and I have had this argument in the past, and I think the straw man that's
we may
always been
have it in a
assigned to
moment.
me is well, you don't like Medicaid, so you just want the poor to die in the streets. And I've always insisted, no, that's not what I want. And now I've had the opportunity to demonstrate that, which is that what I'm proposing here is actually, I would contend, a substantially better insurance benefit for low-income Americans. Why? As I said before, the HSA component allows them to actually save for their own needs, their own financial and health needs over time, build a real nest egg, build actual wealth instead of being completely dependent on the system forever. I think that's very important, very attractive. Secondly, based on our modeling, so as you may know from the plan, there's a metric we use to actually measure provider access and health productivity. That is to say, a proxy for health outcomes. Because I was very concerned about making sure that we could actually improve the quality of health coverage for the poor. So how do we do that? Because they would be on exchange-based coverage in which the networks and the physician acceptance is broader, there would be a substantial increase, nearly double based on these indices of access to physicians and also the access to healthcare services relative to the Medicaid program. I'm trying to find the table here we go. It's table 1 on page 19 of the plan that describes some of these details. And that's something that's very important. And the HSA component is a big part of this. Because what is it that the typical low-income person really needs? Yes, there are the cases of people who've got high consumption of healthcare and are just basically looking for a funding source. But if you think about the typical low-income person has one or more of the following conditions: high blood pressure, high cholesterol, diabetes, smoking, a low health, poor health maintenance, food deserts. Problems like that, right? So what's the common thread in all those problems? It's not actually expensive healthcare services. The pharmaceuticals that treat diabetes, high blood pressure, high cholesterol are all generics. They're all extremely cheap. They cost less than a bottle of Coke. But what these people don't have is access to primary care physicians. And so if you give people the flexibility to take their HSA money, say, and invest that in high-quality primary care, which they certainly could do at that level of support, they could do a lot to actually have high-quality nutritional support, high-quality primary care, high-quality management of their chronic diseases. That's what the vast majority of low-income people need. And I think, Paul Ryan's anti-poverty plan has been mocked because it involves life coaches and some other things like that. Well, it's easy to mock, but at the end of the day, that's what it is that a lot of low-income people don't have, is people who are actually on a human level looking out for them. It's easy to throw money at a problem. It's a lot harder to actually have actual human beings who are skilled look out for people.
Let me jump in. First of all, it's hard to throw money at a problem that affects a marginalized constituency, especially when we leave it to state governments to make some of these critical decisions. I mean, Medicaid, the problem of low reimbursement is a problem that is a state government policy decision that they've made.
Well,
which, by the way,
yes and no. So let me just say one thing about that, because this is an important point. So why is it that states reduce reimbursement rates for doctors and hospitals? It's because it's the only policy tool they really have to keep their fiscal commitments in check in the Medicaid program, because everything else is prohibited by the Medicaid statute. So they can't change the copays, they can't change the premiums. There's so little that they can do, and anything that they possibly can do, they have to apply for an 1115 waiver that takes 3 years and will probably be rejected anyway. So what's the tool that's at their disposal? It's lowering reimbursement rates. So the whole point of this approach is to say, let's federalize the acute care the setup, and so that way the federal government is defining the benefit, is funding the benefit, and that way the states don't really have a role in that problem, and it's also taken off their hands, right? So under this approach, the state governments have no role in funding acute care Medicaid, and they can focus on just regulating the insurance companies as an additional layer, obviously on top of the federal regulation, but not. But they won't have to worry. The reimbursement rates will be determined by the competitive marketplace that everyone else is in.
Well, let me say a couple things about that. One is states actually have more flexibility on Medicaid than you've just let on, and many states have, Medicaid managed care is a very large percentage of certainly of the acute care Medicaid insurance group that you're talking about, and insurance companies that participate in Medicaid managed care can set all sorts of reimbursement rates. Within the existing system, there's actually tremendous variation. I do think relying on state governments to provide basic services to vulnerable people is a huge problem. There's a reason why Medicare is federalized and Medicaid we leave so much to the states. It's because seniors are a more powerful constituency than the traditional Medicaid recipients are. And so I worry about that. In fact, one of the components of your plan to give state governments responsibility for long-term care, I think at least we would have to think very carefully about how to do that in a way that, so knowing that you're backed by the full faith and credit of the state of Illinois in your long-term care needs, that's a little scary.
So let me make a couple of points about that. So first on the acute care side, because this is really important. So remember the acute care side, this is all being funded by the federal government. So the federal government would provide the guarantees. The state's role is as the regulator of state-based insurance companies to make sure the insurance companies aren't doing bad stuff. But there's also, again, a federal layer of insurance as well. And what's more important than that is that you made this point about the marginalization of health coverage for poor people and low-income people. Mm-hmm. One of the great attractions of putting everyone in the same, or migrating everyone to the same system over time, the Medicaid population, the individual market exchange population, the younger retirees over time, plus some people who would come out of the employer-sponsored system and shop for coverage on their own. You'd have so many people in that system that it wouldn't just be low-income people campaigning for high-quality coverage in the exchanges. It would be a large subset of the U.S. population, including some of those politically active and wealthier constituencies that you refer to. So I think if you want actually poor people to get better coverage, one political economy tool that you have to make that happen is to integrate them into the same kind of coverage that other people in the healthcare system enjoy and do very well with. And as we know from the recent study by Summers and colleagues in Massachusetts, the exchange-based plans have done fairly well in terms of improving health outcomes for the low-income population. So all this is to say that I agree with you that there's a lot of problems with Medicaid, and I'm trying actually to consider those problems and do something about them. This is not a plan that ignores or neglects the problems you describe, but a plan that actually quite directly and intentionally tries to remedy those problems and address them. So that's on the acute care side.
Let me make a couple of comments about that. The first thing is a lot depends on how we set up the exchanges. If we set up the exchanges so that populations really separate and poor people end up in a set of plans that are quite different from the plans that other people go in. For example, if you have economical plans with narrow networks that low-income people tend to gravitate to,
they would have no incentive to do that, right? Because they would have subsidies that would be benchmarked to a fairly generous actuarial value, so they wouldn't have an incentive to choose. I mean, they could choose a lower plan and I suppose keep the savings if they wanted to in an HSA deposit. I mean, you could design it that way. But the idea here is that low-income people would have a pretty meaningful insurance coverage benefit. And again, so if you look at the ACA, the way the ACA setup works is typically the people who are eligible for subsidies are choosing more generous coverage than the unsubsidized population. So among the subsidy-eligible population, almost everyone's choosing a silver plan. Among the unsubsidized population, almost everybody's choosing the bronze plan. So it's kind of the inverse of what you're describing. And so I think we have a lot of evidence that if you subsidize the premium product, that, of course, classical economics would teach you, makes people less sensitive to the price of the plan, and therefore they're going to choose a more generous coverage benefit.
But I'll just say one of the things we would have to watch as it moves forward. I do think from a progressive perspective, many of the problems that you identify we could deal with right now within the structure of ACA. For example, ACA went some distance to raise primary care reimbursement rates for for some period of time. I wish that were more generous. There's a bunch of things we could do to raise reimbursement rates in Medicaid just within the current structure right now, and it's really a political question at both state and the federal level. Are we willing to spend the money to do that? And if we're not willing to spend the money to do that within the existing structure, I think we're going to see, that politics will recreate itself in some fashion over time. And that concerns me a lot because we obviously, if we said we really need to get everybody in Medicaid into a good primary care situation, we could do that right now if we were committed to doing it. It's not particularly expensive. One of the things that's striking in Illinois is we spend half of our Medicaid budget on 3% of the people, and if we wanted to provide much nicer benefits to the bottom 80% of the recipients, we could do that. We just choose not to do that.
Well, underlying your set of assertions there is that Medicaid is currently structured is equally as efficient, both in terms of cost and quality, as exchange-based coverage would be. And I would simply disagree with that. I think that exchange-based coverage is more cost-efficient over the long run because the competitive dynamics are such that they drive lower prices and more quality innovation and cost innovation and higher quality.
What's the evidence for lower prices? It seems to me that
So I cited you some of the evidence from Medicare Advantage, and we also have evidence from Arkansas, right? So Arkansas has a situation where they've got the so-called private option, which is far more constrained, by the way, than what I'm proposing in terms of a true exchange benefit, because it's an exchange benefit plus a Medicaid wraparound. So it's not as efficient in that sense as a true exchange-based plan would be, but they're showing, if results from the state government are to be believed, some reason to be cautiously optimistic that the so-called private option, which everyone believed, including myself, that would be very, very expensive for that Medicaid population, may be less expensive than people thought. And we're certainly seeing in the 2015 round of rate increases or rate decreases in the overall exchanges across the country, that the rate increases are relatively in line with broader health cost trends. So I think there's a lot of reason to be optimistic that the competitive pressures that the exchange creates can do a lot to create a higher quality, more cost-efficient benefit. And again, I think one thing I want to emphasize here is that this model shows that for roughly the same cost as the Medicaid benefit, the current Medicaid spending and Medicaid benefit, we're getting dramatically higher access. So your argument is, well, yeah, we could address this problem by spending a lot more money on Medicaid, but if we could get the same level of provider access, the same level of quality by spending the same amount of money, why wouldn't we want to do that instead?
By the way, one of the things I like about the Arkansas approach, they've been one of the reasons, by the way, why I think it's had a good financial projection is that they've been the group of people that they're applying the private option to has been well chosen, and they've been careful. If you actually look at, there are various avenues out of being put into the exchange for people with specific issues, and they've been very careful about
it leans a little healthier than the overall Medicaid population. And I think that's why I say I'm cautious but optimistic about what Arkansas is doing.
By the way, I must say,
there are things like that to study.
Sorry to interrupt. I must say, by the way, I'm very happy with the way ACA is going. After the initial disaster with healthcare.gov, things are going very well right now. And one of the reasons why I'm feeling that, and I have contradictory feelings. One is this is not a great moment to compromise because things are going well, but the other is politically, things on the ground are going very well, but the politics of ACA are not particularly going well. And I think both Democrats and Republicans have to realize this isn't 2008 and it's not 2010 either. And we have actually a very successful set of things happening in ACA, and Republican governors in the Obama administration and others are starting to realize, we really have to start talking seriously about, this thing has happened on the ground. It's a reality. How are we going to work together to make it better and to achieve our different, sometimes conflicting, but sometimes consistent objectives so that this thing is actually working well 15 years from now? because
Yeah.
anyway, I don't know how you're feeling about ACA, but I mean, I'm feeling very good about what's happened once the exchanges got up and running. You look at the rate increases, you look at the reduction in uninsured in places like Arkansas and Kentucky. It's the human story there is really quite moving.
Well, I would vigorously contest the argument that the ACA is going well. I'd say the ACA is going well for the beneficiaries of the ACA. It's not going well for the people whose rates have skyrocketed. It's not going well for the people who've lost jobs because of the higher costs of hiring because of the employer mandate, the people whose jobs have been moved from full-time to part-time. I think there are plenty of people who are losers in the law, plenty of people who are winners, and we can have an energetic debate about whether those trade-offs are worth it. But I think a complete and fair understanding and contextual understanding of the ACA from both sides, frankly, would take into account both the winners and the losers. And I think what the left does is it celebrates the winners and ignores the losers, and what the right does is it highlights the losers and ignores the winners. And I think if you take the whole sweep of it, I think the fairest way to put it is there are losers and there are winners, and the goal of future reform efforts from either side should be to mitigate what happens with the losers and try to preserve the benefits for the winners.
Well, let me ask you. Well, that's a fair point. I think, by the way, we didn't talk about the employer mandate, but I think that is an area where I don't particularly identify with the employer mandate, and I think many of us on the liberal side would be happy to see some sort of a relaxation of it now that the exchanges are working well.
Can I make one quick point related to that? Because it reminds me of something we talked before. You'd mentioned that I bring down the subsidy threshold from 400% of FPL to 317% of FPL. That was done for some specific policy reason. In Massachusetts, they achieved near universal coverage with a 300 FPL threshold in a state that obviously had a relatively low uninsurance rate to begin with, but still the meaningful reduction that everyone sees as the model came from a 300% FPL threshold. And the Congressional Budget Office has actually modeled it out, as have a number of independent places like the Urban Institute, who have said that if you actually reduce the threshold from 400% to 300% of FPL, the coverage impact is minimal because most of the people who are in the 300 to 400% FPL income level have employer-sponsored coverage. So I go with 317 because that is just a smoother graduation of the subsidies. But the idea there is that you want to subsidize and direct the resources towards the people who really need the help, not to people who don't need the help.
But by the way, just for people that aren't FPL experts, that's the federal poverty line for a family of four. 300% of FPL is something like $70,000. I'm not sure. It's something in that range.
It's like $90,000, I think, for a family of four.
Well, we will get the correct number, but it's so just so people have a sense of magnitude. Since one of the communication failures in the conversation about the ACA was to do so much discussion, we would explain there's so many people who are totally eligible for subsidies under ACA who have no idea, who think it's for other people because they don't know what the federal poverty line is and that they're at 322% of it. Now, there is one thing, one thing I like about your plan is near universal coverage. The one tragic thing for me right now is, where I started. Actually, my first campaigning for candidate Obama was calling on the phone rural African Americans in South Carolina and telling them about this Senator Obama guy. Why they had me doing that, since these are, of course, my people, I don't know. That's the mystery of campaigning. And I remember talking to an older gentleman with diabetes, and he was talking to me about his wife had health problems, and he basically said, if your guy wins, will he help me? And it was like a punch in the stomach, because it wasn't like, do you have a Will.i.am video that you can send me? This is like, I got some bills right now. And as you and I know, the best benefit, the most immediate benefit that the Medicaid expansion brings to people is basic financial security and mental health, which you should put into your thing, by the way, in your discussion of Oregon. And I thought, when ACA passed, I thought of that guy, and I thought, I helped that guy, because I didn't know whether I was just BSing him when I said, yeah, we're going to help you, or not. And then the Supreme Court struck, and, all these red state conservative governors who are rejecting the Medicaid expansion have shut out poor people who are not their voters, often are non-white, and we're stuck in this. Now, what can we do about that?
Well, as you know, Harold, I wrote a book entitled How Medicaid Fails the Poor. So I take a much dimmer view than you of the degree to which a low-income person with diabetes benefits from the Medicaid program. And so I think that what I really am energized by with my plan is that I could go to that individual and really, with great confidence, say that this plan is better for that individual than the ACA, because Medicaid is a false promise. It's a card that gives you the false sense that you have coverage, but it doesn't actually give you the care you need when you need it. And that's something that I spent an enormous amount of time, an enormous amount of work trying to change, and being very careful and working really hard because of all the trade-offs in healthcare policy to design a plan that would help those people above all else. Because I think it's very, very important that we call attention, particularly as conservatives, to the poor quality of coverage and care and access that low-income people get, whether they're nominally uninsured or quote-unquote insured under Medicaid. And that's I think something that I think you're right that there is a degree to which conservatives see the low-income voter as not their voter. I think part of it is that there's a philosophical view that we shouldn't just be handing money to people who didn't earn it through work or something like that. But I look at it differently. I say, somebody asked me the other day, said, Ovik, is there a work requirement? A conservative asked me this. Is there a work requirement in your plan for eligibility for these subsidies, these exchange subsidies for low-income people? And I said, no. And the guy said, well, that's a problem. We should have a work requirement. And I said to him, would you ask for a work requirement for a low-income unemployed parent to send his child to primary school? And of course, he didn't answer. And to me, that's how I see health coverage. I see health coverage in exactly the same way, which is for the same reason we would want the child of a poor unemployed person to be able to go to a good school. We should want the child of a poor unemployed person to get access to good health care. And so I share that view that a lot of progressives share, and what I contest is that the Medicaid program is a vehicle with which to do it.
I've spent a long time working with low-income people, many of whom on Medicaid, and I share your concerns that Medicaid has problems as a program, but I can tell you that the overwhelming majority of people on Medicaid are very grateful to have it, and this gentleman in South Carolina would have been very happy to have it. The people in Oregon are very happy to have it, and if you compare the satisfaction of people on Medicaid with the satisfaction of people on private insurance who are similar, Medicaid does very well. And it is, I agree with you, it has a lot of problems. But I think that it is a very bad argument against universal coverage, to point to the defects of Medicaid. And I do think that, I hope that when Republicans read your plan, that one of the things that they take from it is we have to find a way to get everybody covered. We have to do it in a way that is consistent with our principles, and I think Democrats and Republicans have to compromise on that, because neither one of us we can't do it alone, either side.
And that's what I think my role is as a think tank guy. I mean, I think that if you're even a reform-oriented politician, whether you're a Democrat or Republican, it's very hard for you to come up with a bipartisan proposal, because you're going to get attacked by your constituencies, both activists and primary voters, for doing so. I think some guys have tried. I think guys like Ron Wyden have tried on the Democratic side. I think guys like Paul Ryan and Tom Coburn have on the Republican side to come up with bipartisan proposals, Joe Lieberman. And again, these are people on the hard left and the hard right might not like. But I think my role as a think tank guy is to really flesh that out, because nobody, thankfully, can primary challenge me, or at least I suppose they could try. But
Yeah.
That is a strength of being in the academic or think tank world, and I see it as our job to try to bridge some of those gaps and offer credible alternatives to the polarized environment that we find ourselves in.
Well, this is probably a good place to stop. Thank you for devoting a large chunk of your afternoon to talking with me. Perhaps we should have had more vituperative argument to establish each of our credibility with our respective sides. But
you tried.
I did. But people will just have to take a word for it. You're a conservative and I'm a liberal. But But I think that this has been a fruitful conversation, and I really appreciate it and wish you the best of luck.
Thanks, Harold. I really enjoyed the challenging questions.
Thank you.